Hello, and welcome to the second of this webinar series examining trauma and resiliency informed practices in care. My name is Carol Fancott, Director of Patient Engagement and Partnerships at Healthcare Excellence Canada, and I will be one of your co-hosts today. Before we begin, there are some tools to assist with the full participation of everyone who has joined the call today. We are pleased to offer this session with simultaneous interpretation into 3 languages. If you would like to hear the voice of our French verbal interpreter, please select French from the interpretation menu at the bottom of your screen. Please access the View Options menu at the top of the slides to see the slides in the language of your choice. In addition, sign language interpretation is available in American Sign Language as well as Langue des Signes Québécoise. Each of these can be accessed from the interpretation button on your Zoom menu. This session is intended as a space for learning and reflection. Please note that there are supports available in French and English to debrief about the content discussed and to support our well-being. A counselor is available throughout the session and for 3 hours after the session at this number, 1-888-829-5815. And this number has now been added to the chat, and you may contact them at any point during this session and for 3 hours following. If there is a high demand for this service, you may be asked to leave a voicemail and your call will be returned from a private number. You will note that the chat box has been set to allow all participants to chat with our panelists, but not with each other. We assure you that your comments and thoughts are welcomed at any time throughout today's event, and our team is working behind the scenes to ensure key messages will be shared with the entire audience. This is a full agenda today with our speakers, and there will not be the time to discuss questions live today. However, your questions and comments will be collated and responses will be shared after the event. And finally, please note that the session is being recorded and the recording will be made available via email and on HEC's website in the days following this session. So for today, we are gathered together to learn together with well over 3,500 registered participants. And we're grateful to you that you have made the time to spend this next hour with us as we focus on trauma and resilience informed practice and action. If you have not yet done so, please do take a moment now to respond to the poll question on the screen. Please scroll down to see and respond to the question, and please be sure to click Submit to send your response to us. I recognize that we are all gathering virtually today from a variety of places across the country. I gratefully acknowledge being a visitor on the lands where I'm joining you today, here on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples here in downtown Vancouver. Healthcare Excellence Canada is committed to truth and reconciliation efforts with First Nations, Inuit, and Métis governments, organizations, and communities. And we recognize that this is a learning journey that we're all on as individuals and collectively as an organization. And I offer this land acknowledgement as an act of reconciliation, and I reflect on the privilege that I have as a result of the many sacrifices of First Nations, Inuit, and Métis people across this country. And I'm grateful for their enduring presence on these lands. Please take a moment now to reflect on the territory where you're joining us from. And if you're unfamiliar with what territory you're on and the history that has built and preceded it, we have provided the link to Native Land Digital in the chat. So I have the great privilege of co-hosting this session with Denise McQuaig, a Métis elder who has worked closely with us here at Healthcare Excellence Canada. And together we have co-chaired the advisory committee for this virtual learning exchange. Denise is a board chair of the First Peoples Wellness Circle, has been an Indigenous advisor on a number of boards and committees across the country, such as the Mental Health Commission of Canada and Sanyas Indigenous Cultural Safety Training Program. Previously, Denise was also the Director of Aboriginal Health for the Interior Health Authority in BC. As we were preparing for today's webinar, I was reflecting on learnings taken from the first in this series and gaining insights from a panel of presenters who provided their lived experience perspectives of what trauma-informed engagement looks like to them, and how incredibly important it is for us to understand trauma and what it means to create safety in our work from the perspective of those receiving care. For those of you who may have missed this first session, we'll drop the link to this session in the chat box, which you can view at a later time. And I'm excited for today's session, as I know our presenters, Bev and Marika, are going to extend our learning into action. And with that, I'm going to hand it off to Denise to get us started.
Merci, Carolyn. Thank you so much for the land acknowledgement. As that practice has been finding its way across the country as a Métis citizen, it really helps me to not feel invisible. So I'm most grateful for you taking the time to do that. I have the great pleasure of speaking about the advisory committee that's helped us form this learning series with Healthcare Excellence Canada. I am the co-chair of that advisory along with Carol Fancott, my co-host, and it brings together a perspective of both lived experience, pan-Canadian health organizations, and provincial quality councils. And the advisory group has been key to assisting us in developing and delivering this learning series, beginning last year with the COIN model and the examination of unconscious bias and privilege. And then, as Carol stated, most recently looking at trauma-informed care, first from a patient perspective, and now from a systems perspective today. And so I'd also like to thank the advisory committee for their insights that have influenced the number of interpretation options we have, along with the counseling process that we support. I'm now having the great pleasure of introducing the speakers for today. Beverly Pomeroy is a queer researcher, an award-winning patient public engagement specialist, and an uninvited settler person on the shared traditional, ancestral, and unceded territories of the Nanaimo Territory, also known as Gabriola Island, British Columbia. Bev has a particular interest in justice, equity, diversity, and inclusion, an acronym often referred to as JEDI, and has co-developed a trauma and resiliency informed practice program for research and evaluation, a strength-based approach to patient-oriented research. Bev's unique combination of education, professional experience, and lived experience has exposed them to progressively senior leadership opportunities in a variety of healthcare and research environments, from community laboratory services to patient safety and quality improvement. Bev landed in patient-oriented research after her daughter, Sophia, passed away in 2017 from a rare, complex chronic disease at the age of 16. They sit on the board of BC Patient Safety and Quality Council, Oversight and Advisory, Strategy for Patient-Oriented Research Evidence Alliance, and Canadian Association for Health Services and Policy. Joining Bev today is Marika Sandarelli. For over 40 years, Marika worked in outreach, counseling, education, and community development with people experiencing social exclusion from poverty, homelessness, mental health, and substance use issues in several countries in Africa and Central America, and in Vancouver's downtown East Side. For the last 16 years, Marika works in the role of knowledge exchange leader for mental health and substance use services in Fraser Health, where she leads that region's Trauma and Resiliency Informed Practice Initiative. Also, she teaches at Simon Fraser University, where she graduated with a master's in education in contemplative inquiry. With a strong commitment to humane education practices, Marika is a certified mindfulness meditation teacher and canine assisted integration specialist. She lives as an invited white settler on the unceded, shared traditional territories of Kwantlen and Katzie First Nations, also known by its colonial name of Mission, BC, with her partner and 3 dogs, where all are dedicated to expanding ethical animal-assisted supports for learning, social inclusion, comfort, and healing. So over to you, Bev and Marika.
Well, that's a good start. Hi, everyone. Thank you, Carol and Denise, for such a kind introduction and the sharing of supports and such a thoughtful land acknowledgement. I'm Marika, and I'm happy to be joining you on the unsurrendered, unceded, and traditional lands of the Coast Salish and the Inuktitut First Nations, known by its colonial name of the Fraser Health region in the lower mainland of British Columbia. The Trauma and Resiliency Informed Practice program that we call TRIP has been developed in the Fraser Health region. So I'll ask for the next slide. Fraser Health has a workforce of nearly 45,000 employees, medical staff, and volunteers who serve over 1.9 million people in 20 diverse communities, 32 First Nations, now 6 Métis chartered communities in urban, rural, and remote areas. More than 90% of new refugees who settle in British Columbia live in the Fraser Health region. Next slide. So it's no surprise that we're all experiencing higher levels of distress and the workforce, the health and social care workforce across Canada, not just in British Columbia. And as shared by this emergency room nurse, she participated in the TRIP program. And I think what may not be as novel is the intersection or the link between trauma, workplace distress, and stigmatizing behavior. So in her words, and I'm going to read her quote here, "I used to leave my shift every day feeling angry and frustrated, mostly at patients who refused to help themselves or blame others for their problems. Then the guilt and shame would become overwhelming, especially if I was rude or mean to someone that day. I questioned if I was good enough to do this work, then rationalized those thoughts with blaming the patients again. It didn't occur to me that I was in a distress response. I always thought there was something wrong with me, or worse, the patients. I now have the tools and can attune to how I am responding to this distress and find myself less frustrated and angry. I am finding the joy and passion for this work again." So I'm going to turn it over to Bev now, and the next slide.
Thank you, Marika, and thank you everybody for coming today and for attending. As mentioned, my name is Bev Pomeroy, and I am incredibly grateful to be here from the Sinimu region of British Columbia. Quite literally, I'm sitting in the Salish Sea, so I'm super grateful to be here today. So talking about trauma organized systems and some of the work that we're doing and that Marika is doing with TRIP. So we are living systems. We are a sector whose predominant product, both in delivery and reception, is care provided by people, for and with people. If you consider your organization or area in healthcare, they are alive. We work in these living, breathing environments, and these environments are incredibly vulnerable to stress, chronic, repetitive stress. So to set the stage today, we really just felt it was important to firstly understand that we have trauma-organized systems. Dr. Sandra Bloom, who specializes in this area, has, through her research, discovered just that. We have these trauma-organized systems. So just as the lives of people exposed to repetitive and chronic trauma more often are historically underserved populations become organized around traumatic experiences, so too could entire services, organizations, and systems become organized around recurrent and severe stresses. Next slide, please. Evidence shows that crisis-driven organizations sacrifice communication networks, feedback loops, participatory decision-making, and complex problem-solving under the pressures of chronic stress. As an example, in her research, Bloom recorded that the effect of chronic and repetitive stress on social service and caregiving organizations is that these workplaces tend to have problems that actually parallel or mirror the problems of their clients. So in her research, Bloom has shown that organizational leaders as well are more likely to become more authoritarian when in a crisis-driven state. Next slide, please. As we reflect on how to support the system to engage with diverse and hard to reach populations, we must acknowledge two current realities with respect to trauma. The impact trauma has had on the populations that we want to engage with who have experienced the most health inequities, and the impact trauma has had on the healthcare workforce, in particular during COVID and the overdose crisis. If we do not acknowledge and address this trauma, we risk creating relationships and environments where people may be re-traumatized and feel unsafe, creating further barriers for working together to improve health outcomes. It is important to incorporate the recognition of trauma into our engagement practices through a trauma and resiliency informed approach that we're going to discuss today. And when a trauma resiliency informed approach is taken, the communities we engage with will be more likely to enter into relationships willingly and trust that their safety needs will be met. And we know what we know. Healthcare is trauma organized system of care. We know high levels of occupational stress can lead to poor quality, and discrimination and stigma greatly affect care. And really, to highlight what research tells us is occupational distress and stigma are interconnected. Next slide, and over to you, Marika.
Thanks, Bev. So just kind of laying the groundwork in what Bev and I have shared so far. Trauma-informed practice, knowing what trauma is, how it affects people, how it affects the quality of care. We've learned that just knowing the evidence around trauma is not enough, that people that are working in distressed context and service environments are not open and receptive to learning or changing, that we also have to look at how can we support practice change in a highly trauma organized system that's experiencing distress. And the TRIP program was built around that reality. So the places we're going to go today, we're going to start with a little bit of our working definitions of trauma, resiliency, and TRIP, and how did it come to be trauma and resiliency informed practice. We're going to talk a little bit about the theory of change that we developed from practice. We're going to share some examples and stories of change from an individual to a system level and some learning, and then share with you plans going forward. But first, we want to share a few caveats, so I'm going to ask for the next slide. So what Bev and I aren't suggesting right now is that you're doing anything wrong. There's a great line in a Sufi poem that says, "Out beyond the ideas of right doing and wrong doing, there's a field, I'll meet you there." That's the field that I'm inviting you to join us today, as we're all grappling with how to create safe and engaging spaces. We're not saying that you need to do more. This isn't something else to put on that heap that we're all dealing with every day. And in fact, TRIP has taught us that it's more about doing things differently or even doing less. We're not saying that if you practice the TRIP program that things will automatically get better. This is really difficult work, and we don't want to minimize just the struggle that it takes to be able to implement TRIP. We're not saying that TRIP is the best way. There's some amazing trauma-informed practice initiatives happening across Canada. We need them all. They all support each other. We don't want to position ourselves as a competing discourse, but join in all the wonderful initiatives that are happening. And we're not saying that this is easy or even possibly relevant to what you're doing. The next slide. What we are suggesting or acknowledging is there's a lot of parts of our work that may not well be understood by people, that the public facing part of our work, there's so much stuff that happens behind the scenes that people may not understand. We're also acknowledging that small things can make profound differences. It's the confluence of many people and many actions that will affect change, especially in trauma organized systems. and that we measure shifts in millimeters and not miles. I think this is coming from my own maturity after working in healthcare for so long, but I think that sometimes we are the change that we're waiting to happen. We can be the change. Not to say that we don't advocate for change, but it starts with us, and TRIP has really been an incredible teacher around that. We're all responding to our own levels of distress and stress, and we're all, just doing the best we can, and that we're all works in progress. TRIP is a program that's highly developmental. We're still learning. What we're sharing today, I'm sure in a year's time will change as we learn and further develop the TRIP program. Next slide. So we do want to start with a little bit of what are we talking about, TRIP and trauma, what is it? So I'll ask for the next slide. So there are many definitions of trauma. Again, they all can be useful. For the TRIP program in Fraser Health, these three definitions are really contributed to the program. So the first was in 2003 when Covington shared that trauma is both an event and a response to the event. And the response is overwhelming fear, helplessness, or horror, and talks about PTSD. What was important there that up until that time, we only focused on the event. If you were a veteran returning from war, if you were a victim of assault or violence, we only focused on the event. But we learned it's not the event, it's the experience or the response. And everyone can respond differently. Tara Brock's definition that trauma is when we've encountered an out of control, frightening experience that has disconnected us from our sense of resourcefulness, safety, coping, or love, is the foundation of TRIP. So anytime we're creating relationships, clinical decision support tools, physical layouts in our service settings, policies, service cultures, where we're helping people reconnect to their sense of resourcefulness, safety, coping, or love, we're minimizing the effects of trauma. And then Dr. Maria Yellowhorse Braveheart, conceptualization of trauma from more of a decolonizing thinking has really helped us understand that trauma. I'm just pulling up my slides. I'm wondering if people can still see the slides. Okay, thanks. That trauma is an injury or wounding from colonial violence that can be multi-generational and encompass historical grief and loss. Next slide. And I'll turn it over to you, Bev.
Great. Thanks, Marika, for that great definition. So one thing that we're realizing in our journey with TRIP, that it really is a journey and a trip for the work that we're doing. And we've been unlearning and understanding trauma in the context of decolonization. This is a very large topic, and it's not one that we typically have in our principal workshops, but it's something in our Center for Dialogue that we're looking at, having deeper conversations with Dr. Maria Braveheart. But as we begin to reconsider our use of the term decolonizing trauma, we're really beginning to understand that it may be more about decolonizing our thinking and our actions. And the term decolonizing trauma doesn't necessarily acknowledge injuries and wounding from colonial violence, that the term trauma really originates in a Western context. And it doesn't place responsibility on colonization and abuses of powers. There actually was a recently published paper came out of BC. We'll try and put the link in the chat as well. And it just discusses the structural violence and how we have normalized social suffering in this context. So as we're thinking of TRIP, just sort of really being conscious of how we're decolonizing our thinking versus the trauma itself. Next slide. And on that note, so most people know TIP, trauma informed practice, and that there are particular principles that we discuss. So trauma and resiliency informed care, or trauma and resiliency informed practice, has evolved over the years, and in particular, because of the stewardship and leadership of Marika and her team in Fraser Health, it's really sort of evolved from 4 to 6 principles that we consider. So when you're thinking of these, and as I read them out, just sort of consider these in your role, your program, or your service, or as a patient partner, as a natural support, whether it's at point of care, partnerships, co-creation. What are these 6 principles? How do we reflect on these in the work that we're doing? So number 1 being trauma awareness, which I think we're all starting to understand. This idea of safety and trustworthiness, if we're thinking of equity, diversity, inclusion, what does that look like? Opportunities for choice, collaboration, and empowerment. Again, what does that look like for our workforce within our systems of care for patients and their families? Really leaning into strength-based skills building and empowerment. It's one of my sort of favorites. And then the 2 that have been added is this recognition, and again, we're talking about it, equity, diversity, inclusion, this idea of social justice, the recognition of the intersection of race, culture, beliefs, history, ability, class, age, sex, and gender with trauma. And then again, of course, last but not least, really is this meaningful, and sometimes I like to add the word, thanks to Marika and her crew, successful involvement of people with lived experiences. Marika, and next slide.
Great, thanks, Bev. So we've been back in 2013, 10 years ago now, Fraser Health joined other health authorities across British Columbia to implement trauma-informed practice, what we called TIP at the time. And we used an iterative change management design, and we evaluated all of our initiatives. Mostly they were education-based, workshop-based. But within about 2 to 3 years, in about 2016, an unexpected and concerning finding happened. And so it's almost an educator's nightmare. We're teaching about trauma-informed practice. What was happening was participants who attended the workshops were starting to experience a trauma response during the workshop. They now had a framework, they had a name, they could explain what was happening to them, the trauma response they were experiencing, and they were also recognizing that they were traumatizing the people that they were serving, and it created high levels of distress. So we pulled the bus over. We said, we got to stop and we have to revisit what we need to do. So what was happening was the participants were really in a threat response by learning about trauma, and it almost mirrored what was happening in practice. And so this created a lot of dissonance for participants. And so we went out and researched, how can we create some kind of cognitive scaffold or something that can help people when they learn about trauma to be supported and remain open and receptive to learning the frameworks. So what we did is 2 major things. We included mindful self-compassion and started decolonizing our approach and our thinking around trauma. So you'll see the theory of change. It really comes down to, you can't give what you don't have. So it starts with the first gear is, the more that we can practice mindful self-compassion, that we can show up and be attuned to how we're showing up in the workplace, the more we can use those principles that Bev just shared to guide our decisions and our behavior and be compassionate for others. And those 2 converge into this concept called compassion satisfaction. Next slide. So some of you may be aware of compassion fatigue or secondary traumatic stress or distress. We don't use the word compassion fatigue as much because there's not a lot fatiguing about compassion. Compassion can be highly generative, but compassion satisfaction is not something we talk about. And really what it is, it's the positive feeling or the explanatory framework that we experience when we feel connected to our work, we feel competent, we have positive work relationships, that we have that conviction that our work has meaning and purpose and we're making a difference. Most people come into healthcare because they want to alleviate suffering. They want to help people. They want to make a difference. So this is almost when you're in that zone where things are going really well. You go home at night and you can identify something that you did that made a difference. You're experiencing compassion satisfaction. It can be measured. And now we're learning more and more that people who experience high levels of compassion satisfaction are less likely to burn out. They're less likely to feel the effects of trauma in the workplace and less likely to re-traumatize the people that they're serving. Next slide. So now we're going to share. So that gives us the kind of foundation and the history of how TRIP came to be and the concept that informed this program. We're now going to share with you what we're learning and a few stories of change. Next slide. So one thing about TRIP is that we're learning more and more that it can ignite change at multiple levels. So we can start with the individual through people participating in workshops or huddles or centers of dialogue, and teams can come together. We've implemented the TRIP program across teams that can inspire culture change or service organizational change in policies and physical layouts, in intake forms, in decision support tools. It can change service agreements between organizations and affect change at a social political conditions around the fact of even decolonizing our thinking in how we show up in our work. Next slide. So I'm going to start with some of the individual and team changes that we've experienced. So we're quite fortunate to be partnering with the Mental Health Commission of Canada to help us with evaluating TRIP. And you'll see here that here's our methodology. So we have a pre and post design. So people who participate in a 7-hour TRIP workshop, where there are 2 half-day workshops, we do a pre-workshop survey and we do a post-workshop survey, and then a 3-month follow-up survey. And some of the standard instruments that we use in that evaluation is OMPATOS, which is a opioid stigma scale that the Mental Health Commission has designed. We use the professional quality of life. We measure compassion satisfaction and secondary traumatic stress pre and post. We have a resiliency scale. We have the self-compassion scale and some open-ended reflection questions. Next slide. So we've had, here's the sample, because I'm going to share some of our evaluation findings. So we had about 79 participants that work in mental health and substance use services in Fraser Health. We had about 145 doctors and nurses who work in emergency departments across 9 hospitals in our region. And we also had 139 staff that work in maternity, infant, child, and youth services that are hospital-based. And from these cohorts, I'm going to share with you some evaluation findings. Next slide. So you'll see here, these are 4 measures that we measured pre and post. So the blue bars are the pre-scores. So you'll see for stigma reduction, the score 2.7. You can see that post-workshop, so that's post after the 7-hour workshop, that the reduction scores decreased. And here's what's interesting is that they continued to decrease 3 months after participating in the TRIP program. You can see that that correlates with an increase in resiliency in the bottom left-hand corner, The resiliency skills continue to increase, as well as the self-compassion scores. And then, of course, the compassion fatigue or the secondary traumatic stress scores decreased as well. So this is, pretty promising evaluation findings, especially with the 3-month follow-up. Next slide. So on an organizational or team level, we're moving more of an organizational culture level. I wanted to share with you the difference when charting, how we talk about clients, how we write up about clients. So these are client charts. So this is a client chart. This was from a service professional. He had just met somebody that was admitted into an inpatient psych unit in one of our hospitals. And he had met with him for a few minutes. And then he wrote down his clinical impressions in our client information system. So he's saying, so-and-so is a male who has a background history of substance dependence and substance-induced mood disorder. He has an antisocial personality as well, and has been manipulating the system by repeated admissions and then not wanting to do something about his addiction problems. His current GAF score is 71 to 80. So if you were a service provider and you were starting your shift and you read this chart about this individual, having never met him and just read this chart, what would your impression be of this individual? Would you see that, yeah, thank you, instantly have a negative impression? Yeah, that judgment, maybe even this person's hopeless, he's not willing to do anything. So it really, this impression really reduces and space and creates this negative judgment for sure. So this service provider participated in our TRIP program. And if we go to the next slide, he actually went in and updated his clinical impressions. He didn't go back and see the client. He just changed his charting. Same situation, different words. So he said, so-and-so identifies many stressors in his life and admits that he uses drugs to help cope with the strong negative emotions that he feels. He recognizes that the hospital is a safe place for support when he starts to feel hopeless and starts thinking about hurting himself. He is aware of the different substance use programs available in the community, but hesitates to apply for treatment because of the potential loss of employment opportunities and subsequent impact on his ability to meet his basic needs in the community. So if you were to read this instead of the previous charting, what would your impression be of this person before you meet him? Would it be different? Yeah, more empathy, no judgment, empathy, compassion. They need our help. Hopeful, like there's room to move, there's room to connect. So this, yeah, some folks, do you mind if we go back? Can we go the slide back just so people can see the difference between the two? So this was the original impression. And then this team did trip work and actually went in and changed the impression after a half-a-day workshop, because he did this impression in the morning, came to the trip workshop. He was so vulnerable and honest in the workshop and said, this is what I wrote about someone this morning, and I'm going to go back in and change the impression. So you can go to the next slide. Thank you. Wonderful comments. Thank you so much for sharing. I love what you're saying. There's so much richness in your comments around not just being a diagnosis, but really humanizing the individual. Next slide. And I'll turn it over to you, Beth.
Thanks, Marika. So I have the privilege of talking about the elephant in the room, which is the word resiliency, and both working in healthcare as a frontline worker and practitioner, but also as a caregiver for my daughter for so many years. The word resiliency was nails on a chalkboard for me. It just was like the F word. I think I even wrote a blog about it. And just there's this negative connotation about resiliency, that we have to have more resiliency, that we're overlaying more burden on ourselves. So I just want to acknowledge that resiliency can be seen really as a four-letter word, and it's often been used to add more workload on staff or for patients and families. And again, to not provide them the space to be vulnerable and ask for help, which can and does often paint us in a corner. So this is how TIPS sort of evolved to TRIP, the Trauma and Resiliency Informed Practice, and based on recommendations amongst groups that were co-creating and producing trauma resources and knowledge tools to lean more into a strength-based approach. So what we started to do is look at resiliency, the term resiliency, and there's a study led by Dr. Emma Werner, and it's followed a group of children for over 50 years called the Kauai Longitudinal Study. So it followed this group of children born in 1955 on a Hawaiian island from the perinatal period, sort of ages 1, 2, 10, 18, and then again at 32 years. It actually remains one of the longest longitudinal studies out there. And what happened was the Kauai study and Emma's work traced the development paths of a multiracial cohort of children who've been exposed to perinatal stress, chronic poverty, a family environment troubled by chronic discord, and parental sort of psychopathology. And so we see this in a lot of patients and families that come in. And again, if you look at the chart as an example, we're sort of pathologizing people based on the environment that they grew up in. But major findings of Dr. Werner's work were these several clusters she found of protective factors and processes that were identified that enabled most of these high-risk individuals, and again, this longitudinal study, to become more competent and caring adults, that despite their socioeconomic status and those risk factors, a third of this group has not only survived, but thrived throughout their life. And Dr. Werner discovered it came down to 3 protective factors. And this is how we build out this term resiliency. Then Dr. Joel Brown then coined the term activating resilience, that we're activating resilience. We can provide that activation to patients and families and natural supports and to staff working in these systems of care. And those 3 protective factors is so simple: caring connectedness, opportunities to contribute, and clarity of expectations. And as a patient partner, as an advocate for my daughter, as someone who works in the system and an engagement specialist, this really resonated with me as someone who's always curious about our experiences. It just deeply resonated. And I began to consider how we activate resiliency in our partnerships, be it at point of care, partnerships, co-design, patient-oriented research. And so what I started to do was develop this activating resiliency tool in the world of patient-oriented research. And there was a team in particular in BC that I was working with. It was in long-term care assisted living. It was sort of 1 year post sort of the beginning of COVID as we knew it. And again, long-term care assisted living, so including residents, families, frontline workers. And it was to create a research team, a co-productive research team with families and residents who had been impacted by COVID and frontline workers. So you can imagine this group coming together with a bunch of researchers who are really wanting this group to help inform and influence research. And we really wanted to see how we could do this in a really meaningful way, but again, not to activate trauma or to reactivate some of their experiences that they had that were really quite difficult and challenging during COVID. And so what does that mean when we want to activate resiliency around caring connectedness? What does that look like? Opportunities to contribute and clarity of expectations in that engaging of a group that had been deeply harmed during COVID. And so some things that we did really, again, doesn't seem like it was super challenging, but again, if we don't think of it or have the framework of that activating resiliency, I'm not sure we would have got there. So the group wanted paper documents. I mean, the average age of this group was 75 plus. So we sent out a beautiful portfolio with all the meeting documents, crayons, a water bottle. We had a graphic facilitator to capture their thoughts and ideas in real time on Zoom. We had clarity of expectations. So yes, become a part of our group and engage to help inform and influence research. But here's our limitations. Here's what you're going to expect when you come to each meeting. What can we influence in research priorities. And so really being clear about those expectations. And again, providing opportunities to contribute for anybody that works in long-term care assisted living. Wi-Fi is terrible and sucks in those sort of buildings. And so we had some residents that were actually calling our researcher, our principal investigator, and they were there on the audio only during the meetings. So again, it seems really simple, but just consider that. What are the tools that we have to activate resiliency in our engagement and partnerships, in particular with groups that have maybe been deeply harmed in the process of care that we've been providing. So I've used this over and over and over again: caring, connectedness, opportunity to contribute, clarity of expectations, activating resiliency, and putting the TRIP principles into action through that methodology. Next slide, please. And again, this is another way that we've put TRIP into practice, and that words matter. So TRIP really has influenced how we engage people with living experience and their natural supports in various ways. And language matters is an example, and Marika just touched on it as well, just in regards to how we put in our notes on patients. So the words used to describe individuals' identities and experiences and circumstances we know can shape perceptions. We saw that when Marika was talking. Language is integral to equity and inclusion. And as the words used in health have the potential to disrupt or further oppress patients that are walking in the door, and even staff. When language misrepresents people, they are misunderstood. This is a significant concern when equity is the objective of our work, as misunderstandings lead to misdirected priority setting, and again, leave inequities unaddressed, or worse, quite often exacerbated. And language can make oppression covert. We don't always know that the language we're using is actually being oppressive. Words can assert perceptions that there are normal or general ways of being, and imply that experiences outside of normalcy are not worth examining. So normalcy is a social cultural construct that governs who is worthy of power and privilege. Language that is inclusive and specific has an important role to play in better understanding disparities and inequities experienced by systematically under-resourced populations. And there are a number of resources that we tapped into, one being the BC CDC language guide. As an example, we shifted hardly reached populations versus hard to reach. And you can see the difference, or maybe if you can share in the chat those, because we can see that, like the difference between changing the word hard to reach, which is putting the onus on that population, to hardly reached populations, which really puts the onus on us to do that work and to engage. When we begin engaging with a group or team, we always start to create a list of words to retire. So I'm non-binary, I'm non-gender conforming. So having language that reflects gender additive terms resonates with me and creates safety and trustworthiness for me. So mental health and substance use, we started retiring words like non-compliant. Instead of drug seeking, we use the term seeking relief from pain. Again, just ask. And part of the TRIP in practice is that language matters. And just really encourage you to share this practice in your engagement work. Walk around your site, look at program policy language. This is a TRIP practice that we've had, and that's had great impact. Both Marika and I do a lot of sort of consulting work and coaching on placing TRIP into practice through language of policy, of processes, of procedures, and of standards. But again, we have these sort of lists that are ongoing of words that we're constantly discovering from our partnerships of words to retire. Back to you, Marika. Next slide.
Thanks, Bev. And I think one of the ones, Bev, that I recall was, it was such a liberating moment where instead of attention seeking, we use the word connection seeking. And I just remember for that patient partner and the natural supports, when we talked about someone was connection seeking, just the kind of emotions that came out. And so many possibilities. I remember her saying, that's exactly what I'm looking for. I'm looking for someone to connect with and someone who understands what I'm going through. And you know, that shift just opened up an incredible spectrum of possibility and less defensiveness. So some great examples. Another thing that we'd like to share with you is how TRIP is inspiring change on an organization and across organizations around even physical spaces. we have a project called Welcoming Spaces in Fraser Health, where we partnered with patients and clients and families and natural supports to learn how we can create safe, welcoming, and inclusive spaces. And so part of it was just changing the signs. When someone has the courage to ask for help and go into a healthcare facility and they see, don't do this, don't do that, do this, like all this command language can be quite shaming and overwhelming and create a negative response to someone that's already feeling quite distressful. So we just changed a lot of the language and created more welcoming language. We have land acknowledgement signs. We really have, we created artwork with patient partners of different images that would be more warm and welcoming and comforting. We also changed the room numbers. We numbers through institutions of assimilation known as residential schools. People were numbers and people were dehumanized. So instead of having just room number 529, we called it the spring room, where people go into a clinical practice and they were able to, here's the spring room that you see right now. In some of our sites, we have all of the native trees of British Columbia. We've got the cedar room, we've got the willow room. We really changed the language that we use from sheer numbers, which have hurt a lot of people in the past that have been highly traumatizing and dehumanizing, to more familiar names. We've encouraged our clinicians to depersonalize their clinical spaces. Sometimes clinicians, not out of maliciousness, but maybe have pictures of their children or birthday cards from their children or on the wall to bring a little bit of home and familiarity. But if you're a client that has lived in foster care or had your children removed from your home, it can bring up incredibly traumatic, painful experiences. So we really wanted the rooms to reflect something that people are quite familiar with. It's not like you're walking and imposing on someone's space. It's your space as a patient or client. And so, pictures of nature, calm, soothing, things that you're exposed to every day was more familiar, more comforting. And also the choice of chairs. You can see in this picture here, you have chairs with arms and without arms. And that's important because we learned from the people that we serve that many times having that choice is critical. People may have been restrained or tied in chairs. People may have been feeling like they need the arms for security. People are different sizes, have different preferences. So we always have that choice of chairs with or without arms. And hopefully in settings where chairs can be moved so you can sit closer to family members who are there to comfort and support you. So these were some ways in which TRIP has actually changed our physical spaces. Next slide. So those were a few examples. And Bev and I also mentioned that, we review clinical support tools and policies and language and for positionality. So we've got other examples, but I wanted to share a little bit before we end this webinar about where we're going. So next slide. So right now we have an evergreen core curriculum, and we have been working to decolonize the curriculum and the implementation through our thinking and our actions, validating the content. So we have evergreen content, and then there's adaptations or modules for specific populations or specific settings. So Bev is going to be launching some work on a module for patient engagement. So trauma and resiliency informed patient engagement. We've been working with our local RCMP, and there's one specifically for policing services, one for long-term care that's coming up. We're also doing a facilitator development program. So to be a facilitator, it doesn't mean that you have to facilitate workshops. You can facilitate reviewing clinical decision support tools or policies. You could be somebody that's, facilitating huddles, facilitating our center of dialogue. So facilitation, there's about 15 roles that you can have. And we do a fairly comprehensive facilitator development program, which is supporting a national diffusion and scale up and spread of TRIP right now, with the help of funding from Health Canada and our partners at the Mental Health Commission of Canada. We're continuing to evaluate. We've been focusing on the workforce. So it's people who work in healthcare. So the evaluation findings that I shared earlier, that was for the workforce, but now we're going to be moving to the point of care. So how is, supporting the workforce affecting the quality of care and patient partnerships and supporting caregivers. We have a center of dialogue that Bev's leading right now. So a lot of the more highly sensitized concepts around TRIP and how TRIP is being implemented on those multiple levels gets shared in the center of dialogue. We meet every second month and have quite a few people attending that. And then we're also putting together a case exemplar. So we're going to have volumes of how all the TRIP change stories, what's contributing to that change. It's going to be a bit of an implementation guide, but it's going to be based in case exemplars. And then looking at a bit of an organizational readiness checklist to support people on how to optimize TRIP. So next slide and final slide. Bev and I really want to thank, we have so much humility. We're just two people here in a very privileged position to talk about TRIP, but there are so many people that we're bringing in the room that have contributed to the TRIP program. We work with Indigenous elders and knowledge keepers across North America. We work with people with living experience and families and natural supports, and a lot of service providers. And our partnership with the Mental Health Commission of Canada has been invaluable. So thank you, everyone. Turn it over to you, Bev, to say final words.
Oh, wow. Yeah, just to echo Marika, thank you everybody for attending. And really, this is a large effort and intention to do this work. And we're super grateful to be in the space to share that with everybody today.
Is that better? Okay, so sorry. So super excited about your references to the link between trauma, workplace stress, and behaviors. And a big comment to me, your reference that entire services can be organized around trauma experiences. In my community, we call that blood memory or epigenetics from a Western paradigm, but it's that idea that I can be an intergenerational survivor of residential school, even though it was my grandmother who attended and not myself. And so what resonated for me in that statement, entire services can become organized around trauma experiences, was to begin to question whether there is a risk for our health system in adopting trauma ways into the way in which we work around here. And I want to dive even deeper into the idea that are these trauma experiences in the delivery of healthcare creating a root cause for systemic racism. I appreciated your 3 pieces of focus: event and response, the disconnect from resourcefulness, safety, coping, or love, and the historical component. And I thought that it really spoke beautifully to the idea of unlearning and understanding that Bev talked about. And the idea, Marika, that you shared in that sometimes our focus on the individual is that they are responsible for their response to trauma. Because I worked primarily in mental health and addictions during my career, it made me think of that stigma that we often see where individuals are assumed to simply be able to deal with substance misuse by making a different choice. And yet we don't bring that same stigma to other illnesses. So no one implies that you can choose not to have cancer or choose not to have diabetes, but there's that underlying stigma around choice related to trauma. The focus on resiliency was also extremely helpful for me in being attuned to how we show up in the work. That's such an incredible component of patient quality and safety, but that it could fill our cup and re-energize us to have joy in the career path that we have been passionate about and chosen for ourselves, I think was a really important piece. And that words have power and they matter. That example of change in charting really filled my heart. In our community, we look 7 generations behind and we look 7 generations forward. And so the idea that we can be the change in the health system by being trauma informed. I love the slide where you put us as health human resources in the middle and you showed how personal change can have that ripple effect, like throwing a stone into the water. And so I challenge you to be the change because you are the new ancestors. And 7 generations from now, people working in our health system will be looking back at what you have done. And you will have become the ancestors of the healthcare system. So merci to both of you and to all of you who have joined us online today to expand your learning and to think about how to unlearn and think about being trauma informed in care. Over to you, Carol.
Thanks, folks. And thank you, Denise, for those closing reflections, and just echoing my thanks to Bev and Marika. And definitely from what I saw coming through the chat, your words, your teachings were really resonating with the audience today. I know we are over time, but I just want to give a quick heads up around what's coming next. Before I do so, though, I also want to just offer a huge thank you to the big crew behind the scenes, from our learning systems team, the many, many producers and interpreters who really were working hard to create a positive webinar experience for us. And I know, again, based on the chat, there was a lot of activity happening. So thanks, thanks for all you do behind the scenes. So looking forward to the future, we are creating a 3rd series for this learning exchange, which is going to happen in May and June, where we will continue to build on these past sessions to advance our learning. In particular, coming back to that first session of how do we put the COIN model framework into action. So the next series is going to examine practical approaches to mobilizing action among those with power and privilege, and living experience toward collective action, equality, and inequity. And so these sessions are going to feature case studies from across the country that showcase programs designed to address inequity within health organizations and health systems. So please look out for more information about these sessions and how to register. And in closing, we do ask that you respond to the poll that is on the screen. And again, a final thank you